Neurology at SAT Hospital Medical College. After Dr. Anandam, he has built up a beautiful department. And before he left the department, he made sure that there is a DM course in pediatric neurology, an achievement par excellence. Probably one of the very few centers other than All India Institute and PGI. So he is going to give you a talk for next 1 hour, and 12 o'clock sharp, we will have the inauguration. Thank you.
Pediatrics, the adolescent pediatrics, breastfeeding initiative, and everything in pediatrics. And now he has even gone up to geriatrics also. So today, so first of all, I thank MKC for the nice comments as well as for organizing this program, and then Indian Academy of Pediatrics for exemplarily celebrating or organizing various developmental disability programs. So, as per the request of our members and Dr. MKC Nair, I'll be just going into the early neurodevelopmental disorders which can be detected in an early phase, and how pediatricians can help in the management, at least in the early phase, not after the diagnosis. So DSM-5 classification, which has come in 2013, gives neurodevelopmental disorders as a separate entity in which intellectual disabilities, communication disorders, autism spectrum disorders, and attention deficit hyperactivity disorder, specific learning disorder, motor disorders, and other developmental disorders are included in that. So we'll start with the major approach. So whenever we are suspecting a neurodevelopmental problem in a child, either it can present as a cognitive delay or as a motor delay, or it may be a combined problem. So then we call it as a global developmental delay before the age of 5 years, and after that it may be called as either intellectual disability or those disorders when there is a motor manifestation is more, we call it as a cerebral palsy. So whenever we are encountering a child with a cognitive delay or a motor delay, we have to consider whether it is a static disorder or a progressive disorder. So static, all of you know that it is either it can be a central static disorder, that is cerebral palsy, or a peripheral static disorders, because we use the term benign congenital hypertonia to say that. And then the progressive disorders also can be peripheral or central. One example of a peripheral disorder is spinal muscular atrophy, which will be, all of you know that it will be progressive in a various manner. In a very young infant, that is type 1 will be rapidly progressive, type 2 may be progressive, but at least they will be able to be in a wheelchair and may live up to 20 to 40 years. And then the other third variety which may present in the later childhood or adulthood is the type 3. And then the progressive central motor disorder would be various neurodegenerative disorders like lipid storage diseases, like Tay-Sachs disease. Then a combined motor system as well as a central nervous system disorder also can present either as a progressive disorder commonly, and very rarely as a static disorder. Such example would be the secondary systemic disorders secondary to malnutrition, various types of nutritional deficiency syndromes, including nowadays the rampant vitamin D deficiency, also can have at least some systemic and developmental impact. Then endocrinopathies, especially hypothyroidism, growth hormone deficiencies, etc. So if you identify these things, they are definitely treatable also. So whenever we are encountering a problem in a child with a disability, always think that they will be able to pursue their own activities, and they will develop their own methods for circumventing the disability. Okay, I think this video, yes. Here, some of you will be familiar with it, but again, here you can see that he has severe dystonia, he has a severe disability, he is not able to use his upper limb at all, he has orofacial dyskinesia, but the same person you see, he has developed his own method of using a pen, he is able to write with that. So that means don't write off anybody with a disability. That is why we use the term differently abled. So we have to recognize their different ability. So for a clinical approach, because when a neurologist is speaking in a neurodevelopmental disorders and neurodisabilities, I'll be trying to help give a neurological approach to this diagnosis, so that labeling is very, very important, and labeling will help in identifying an etiology, and by which you can get a diagnosis. So usually it can be either a hypertonic infant or a hypertonic infant. In both situations, you can have a cerebral problem for the delay as well as regression. And again, you can have a motor system problem starting from the spinal cord, like hereditary spastic paraplegia, where the manifestation can start even in the infancy or at any age. And then an anterior horn cell or a root disease, peripheral nerve, and muscle diseases. But when you are encountered as a pediatrician, you never stop short with a neurological problem, because the same thing can be manifested with a chromosomal anomalies. That means here again you have to think of other etiologies. Again, I use this picture to demonstrate thyroid dysfunctions. For example, as I have mentioned, hypothyroidism must be looked for and should not be missed in any case, because we know that even in a child with a chromosomal disorder, additional hypothyroidism being another problem the child is having. So that per se or an additional. So these things also you have to remember. Various chromosomal disorders, starting from a well-known Down syndrome to, for example, a Mowat-Wilson syndrome or a Wolff-Hirschhorn syndrome, like any disorder. That means where we'll be able to identify nowadays with a chromosomal microarray only. So, but before that, clinically, you must be suspecting such things, so that the unnecessary investigations and the streamlining of investigations can be done. So this is so that means your idea must be to identify whether it is a chromosomal problem, whether it is a brain problem, or it is a spinal cord or a root or a muscle disease. So for that, again, clinically, I'm not going to ask you to do a full-fledged neurological exam. It has a pediatrician or a physician. By certain simple clinical examination, you must be able to identify the basic problem. But for a characterization, you will have to go for a detailed investigation. But at least you will be able to answer the parents' concerns. So, for example, a child is coming to you with a developmental problem with poor muscle function. So you keep the child just in the prone position and see how the child is lying down. And you all know that by the seasoned pediatrician will know that this child is in the frog leg position. Definitely it's a hypertonic infant, and most probably must be having a lower motor neuron disorder. And as the child grows, again, they will have the muscle wasting, severe scoliosis, and other manifestations. So one must be able to identify that thinning of the muscles, etc. And they can have further growth problems later with severe neck muscle weakness, again thinning of the muscles, lordosis, scoliosis. So all these things will tell you that definitely this child is having a neuromuscular problem. So that is lower motor neuron disorder with the predominant hypertonic manifestation. And again, then you can just lift the child and see what is happening. Okay, here you can see just you are doing a vertical suspension in that and see what is happening now. Okay, see, just lift the child. I think I presume that you people are seeing the video there, and there you know that this is a hypertonic child rather than a hypotonic child. So there is definite scissoring is there. So by simply handling the child, vertically suspending, you are seeing the manifestation. Okay, and again, by this vertical suspension, you know the problems. Say here, you can see that this child who is having a, again, that floppiness with a slipping, is this one is a low motor child, and this one is a normal child. You can see that the flexion of the upper limb, lower limb, and keeping the holding very easily. See, again, adducted. This one is abducted because cannot adduct. And again, this is a stiff child. So this one is a stiff child. So definitely we can differentiate by just doing a vertical suspension. And again, if you are keeping the child in the prone position, again the supine position, see, usually again you can see that floppiness there. And instead of bringing the hand up, he is turning the head towards one side, so that the proximal, see, the proximal power is weak here. So this child is having a proximal weakness. Again, think of some problems which can involve the proximal region. And the proximal weakness either would be due to an anterior horn cell disease or due to a muscle disease. So these are some of the simple techniques. And again, you see that look for any abnormal movements, as in this case you can see definitely this child is having a orofacial dyskinesia and abnormal hand posturing, so dystonia or a chorea. Again, it must be an extrapyramidal problem, so looking at that. And then you can make the child just do some motor maneuvers. For example, in this child, let's see there. Okay, look at that. Video അതിന്റെ ഒരു സ്ട്രീമിംഗിൽ പ്രശ്നം വരും. Okay, if it is not working, no problem. We'll go to that. Anyway, this child was having a difficulty getting up from sitting position. So that is there. And then the same child, you keep it in the prone position and ask the child to get up, they raise the head. Because if there is a weakness, definite weakness of the neck muscles, then you can see, understand that there is a weakness, definite weakness, because in the sitting position, if you ask the patient to flex, the child will be able to flex the neck. So there won't be weakness, may not be detected. But the same child you keep in the prone position as well as in the supine position, ask the child to raise the head against the gravity, then that means definitely there is weakness. That will indicate that this child is having a neck muscle weakness. And you know that there are certain specific disorders where a neck muscle weakness will be there. So by that, you can identify that problem. Similarly, you just ask the patient to outstretch the hand. See, outstretching the hand also will give you lot of ideas. For example, in this case, you can see that the child is able to lift the hand very prominently. There is no problem, but there is a wrist drop is there on one side, and there is a clawing on the opposite side. I just kept this to demonstrate that, because if it is happening wrist drop on both sides, then you know that there is a distal weakness due to a peripheral polyneuropathy. But in this child is having a wrist drop on one side, means there is a, all of you know, whenever we think of a wrist drop, you know that it is a radial nerve palsy. Okay. And when there is a clawing, you know that there is an ulnar nerve lesion, Or it may be if it is full clawing, it is median plus ulnar nerve. So in this case, this child is having multiple cranial nerve involvement, and we have to undress this child, and this child was having a Hansen's disease. So Hansen's disease as a manifestation of multiple mononeuropathy multiplex. Again, this child, when the initial diagnosis, because of the developmental delay, a cerebral palsy diagnosis was done. And the physiotherapist was doing the physiotherapy, and because the physiotherapist did not get any improvement, he brought the patient to me. And by the time, because we all know that in our pediatrics OP, we never allow father to come to the OP. So mother will be carrying the child. But here, before the physiotherapy, mother carried the child, father carried the child, and so the physiotherapist brought the patient to my room. And by the time the father was bringing the child to my room, I found that the father is having this sort of a wasting. Foot drop was there. He was having a wasting of the upper limb also. And I asked the father to carry the child, and then found that the child is also having a foot drop. So this was a case of a hereditary motosensory neuropathy. So that means by inspection itself, you don't have to even examine. So by this sort of an approach, we'll be able to identify whether it is an upper motor neuron problem, as we can, whether it is a normal child by this thing, or a lower motor neuron, or an upper motor neuron. Again, there are some more tricks by which you can see whether, so you are a floppy baby, you don't know whether this child is having a hypertonic cerebral palsy, or a spinal muscular atrophy, or a muscle disease. So just keep the child in the prone position and try to put the child up. And you can see that there is definitely head lag is there. So head lag is there. So what you do, you just ventrally suspend the child. And in this case, you can see that the child there is so floppiness, a ragdoll appearance, not lifting the head up at all. So this is a case of peripheral neuropathy, peripheral disease. Either it can be spinal muscular atrophy or a muscle disease. Again, you will have to rule out whether the child is sedated or something is there or like that. That is important. And again, see here, another child, here again, you are doing the same thing. You are pulling the child up. And you can see that there is head lag present. And you do the ventral suspension and see what has happened. There is a head up. There, see the limbs are kept in the stiff extension. Again, stiff extension. So this is a central disorder. So definitely it must be, if it is a static disorder, it will be a cerebral palsy. Again, I will show you another one. See. Severe head lag, severe head lag. But the same child, when centrally suspended, see what has happened, the child is able to keep the leg up, head up, and stiff extension is there. So this is again a central disorder. So this way we can differentiate an upper motor neuron disorder from a lower motor neuron disorder. Again, so we have done it, and now we have a child with again, the vertical suspension, you are suspecting whether it is a lower motor neuron or an upper motor neuron, as you can see here. You know that, as I have mentioned, hypotonia can occur in a cerebral palsy or in a spinal muscular atrophy or a muscle disease. So what will you do? You just try to elicit the reflex. Even your finger will be enough. And see what has happened. Keep the child in the correct position and see here. The reflex is well elicited. And if you look carefully, you can see that there is a crossed, that is the adductor spread of knee. So when you are able to elicit the reflex, definitely it is not a low motor neuron disorder. That means it is not a spinal muscular atrophy, it is not a muscle disease, but it is a upper motor neuron disorder. So if it is a static disorder and upper motor neuron, then it may be a possibility, maybe a cerebral palsy. So then we may have to identify the different types. But by the developmental delay, I think you will be able to identify the type of abnormality. And then our aim must be to identify an early diagnosis of a cerebral palsy. So how will you diagnose it early? Because in last because this is my third talk in this disability week observation. Here, here I thought that I'll be just highlighting the early diagnosis because I have discussed the other aspects. So high risk factors you have to look for. For example, a child with a low gestational age, then or a multiple gestation, transient hypothyroxemia in a premature, they are all considered as a additional high risk. And then with an intrauterine infection, a 9-fold increase may be there. And disorders of coagulation, again in a mother or a baby, again may be considered as a high risk factor. And definitely asphyxia, placental abnormality can lead to various type of embolization and again possibility of a stroke. And maternal mental status, mental retardation, all are high risk factors. So early pointers in a cerebral palsy would be in the newborn period onwards. You can look for any soft behavioral symptoms like colicky behavior, feeding problem, irregular sleep pattern. Because today morning also I was discussing about the importance of establishing a feeding in a newborn. Because that is very many times we will be considering feeding problem as a problem of the mother. But many cases it will be the problem of the child. So we have to identify the problem early and rectify it. Similarly, certain other neonatal factors, pointers like lack of aware alertness, decreased spontaneous mobility, increased abnormal movement, tongue thrusting, even subtle seizures and fisting, that is the persistent grasp signs. All these are important. And certain other abnormal signs of a developmental pattern, like variation in the sequential development, reduced head circumference or a fall in head circumference, because starting from the newborn period itself, we can then delayed the social smell. Definitely, I'll be coming to that. Delayed disappearance of the neonatal reflexes and late appearance of the postural reflex or infantile reflexes like Landau reflex or a parachute reflex. Then persistent asymmetry, because some amount of asymmetry in the early neonatal period because of the asymmetric tonic neck reflex. But if it is persistent, definitely like a posture, movement or reflex, always look for an asymmetry would be definitely a sign of an abnormality. Then looking for a variation in the tone in the form of a persistent hypertonia, or dystonic posturing, because dystonia must be highlighted because even though we were all taught about choreoathetosis, spasticity, etc., dystonia is not that given not that importance. But dystonia is definite. Dystonia means an abnormal posture. It's very, very important. And then poor hand regard after 6 months, stereotyped abdominal movements. All these are certain abdominal early pointers. And again, look for various ocular abnormalities and lack of response to sound. So these are because if a child is not attentive to the human face, or not turning to the sound. For example, a child must be turning to the head by 3 months to the level, at the level of ear, 5 months above the level of ear, and 7 months if a sound is produced below the level of ear. So this sort of lack of attentiveness to the sound. And then coming to the early infancy, other findings as we have mentioned, excessive lethargy, high-pitched cry, poor head control, even in the newborn period, weak suck, all these things, and oral hypersensitivity. And again, apnea, which is persisting beyond term, is also an important point. Okay. And in later infancy, inability to perform motor skills like controlled hand grasp by 3 months, rolling over by 5 months, and independent sitting at least by 8 months is definitely an early indicator. And after 1 year of age, abnormal developmental pattern, delayed development, all of you know, even if a child has attained certain milestones, because if the child is sitting in the W position, or a persistent bottom shuffling, or walking on tiptoe, or and a commando crawl. നമ്മുടെ ഒന്നും തോന്നില്ലേ ആണോ? പക്ഷെ അത് കണക്ട് ചെയ്തെന്ന് തോന്നുന്നല്ലേ, ഒന്ന് ഇത് ഡിസ്കണക്ട് ചെയ്തല്ലേ. ഓക്കെ, I don't know whether there. I think it is there, അല്ലേ? പോയിക്കൊണ്ടിരിക്കുക. Okay, now it is there. Okay. So hand preference by 12 months, excessive arching of the back, log rolling, and abnormal or prolonged parachute response. And again, a simple method to remember the development. For example, head up by 1 month, chest up by 2 months in the prone position, upon elbows by 3 months, and upon hands. That means by 4 months, and sits with support. These are some of the early signs. Again, certain unital reflexes also, if it is persistent beyond this time, for example, rooting reflex, or a moro persisting by 5 to 6 months, palmar grasp by 6 months, and asymmetric tonic neck reflex, so it must disappear by 4 months. So if it is persistent and a negative parachute and a landu by the age of 6 months, so at 6 months, if all these things are there, definitely it is an abnormal pattern. And then in the early phase, hyperreflexic signs, like as I have shown, the adductor spread of the knee jerk, or a heel reflex, or a hand wrist reflex, are definite signs of hyperreflexia. For example, this hand wrist reflex, where you can just elicit the, let me see whether it is working. Again, you just tap on the heel, and if there is a heel forward thrusting, definitely you can think that it is an abnormal one. And already we have mentioned about the quality behavior in the early infancy, tongue thrusting happening in the early infancy, and the persistent asymmetric tonic neck reflex. You can see the asymmetric tonic neck reflex, as I have mentioned, the arching. All these are up. And always I speak about this MGC's path-making invention, that is developmental observation card. A child who has not developed social smile by 2 months, head holding by end of 4 months, and does not sit by 8 months, and standing by 12 months, is having a definite abnormal developmental pattern, and you must start intervention. And as I have told you that scooting or since bottom shuffling is definitely an abnormal sign. Either it can be due to a diplegic cerebral palsy or due to a muscle problem. And similarly, this sort of a bottom shuffling, this again is a definite abnormal indicator. Okay, you can see there. And for a hemiplegia, again, a simple technique like this, for example, where do this cover testing. Just cover the child by 6 months, they will be doing this. And if there is a hemiplegia or weakness, they will be always losing one hand only. We can use the term cover, and that means a child who is a hand preference before 2 years, again, must be having a hemi syndrome. And adductor angle, other Hamilton's angle also will be a useful indicator. For that, this is the system by which I tell the. So just remember that 40 to 160 is the range, 40 to 80, 80 to 120, 120 to 40. And if there is any limitation of the adductor angle, you know that there is a spasticity, and you start early intervention. So right stimulation at right time would be the best thing. If you identify any of the above problems that I have discussed, go for delay. പറഞ്ഞവര്. ഷെയറിംഗ് സാധനം വന്നല്ലോ. എത്ര പേരെ കാണാതിരുന്നു? ഇതിൽ അവർ പറയുന്നത് ഇതിനകത്ത് കേൾക്കുന്നില്ലേ അന്നേരം? ഇപ്പൊ ഷെയ്ഡായോ? ഷെയ്ഡ് നിങ്ങളൊരു വേറൊരു എക്യുപ്മെന്റ് നോക്കിക്കൊണ്ടിരുന്നാൽ മതി. ഷെയ്ഡായല്ലോ അല്ലേ? ഓക്കെ. Okay, simple technique like this. You ask the mother to carry the child straight and ask the mother to do this movement. That is easiest thing. Okay. So now going to the other neurodevelopmental problem that is very, very important. That is attention deficit hyperactivity disorder. How to detect early and again support a child. Here again, you can see that whenever a child is coming to your office with this problem, he is always on the go. Think that he is having a neurodevelopmental problem. He is not a misbehaving child, but he is having a neurodevelopmental problem. Many times we all നമ്മളെല്ലാം പറയും വളർത്തു ദോഷമാണ്, നല്ലപോലെ നോക്കാത്തതുകൊണ്ട്, അതുകൊണ്ടല്ല. So it is a neurodevelopment problem, and even though they want to focus, they can't. They want to perform, but they can't because they are having a problem in their brain. And even at the age of 17 years, actually this child, you can see that at 17 years, this child was having school truancy. He stole 2,000 rupees. He had to be changed from 3 schools. But see, as an infant, he was having an incessant cry. So that means very early itself, some pointers for an attention deficit hyperactivity disorder will be there. And our old education systems nowadays gives care to children with attention deficit hyperactivity, and even the lay press also gives importance to that. And definitely it will be a problem at home and at school. And you all know the triad of, because a triad approach will be easier: ADHD, inattention, hyperactivity, and impulsivity. What are the early signs? We'll just see what are the early signs for this diagnosis. Because there are a lot of excuses will be there for them because they may not do the homework, and see the excuses will be like this. But you want me to visit your home base to see your homework? And this was known from time immemorial about the fidgety Philip, about the attention deficit hyperactivity disorder. And DSM-5 states that the behavior must be developmentally inappropriate. That is it. Substantially different from that of other children of the same age and developmental level, and must begin before the age of 12 years, and must be present for at least 6 months, must be present in 2 or more settings, and reported by independent observers, and must not be secondary to another cause. Then we will make a diagnosis of ADHD. So what are the early pointers? Because how early we can diagnose? Because as we have mentioned, the labeling may be done only after the age of 6 years. But you can identify them, and you definitely can start intervention. Because children with ADHD often have a harder time sitting still, even for a few minutes. They make, and many to a 2-year-old child, you know that they will be incessantly talking. But who is continuously talking and asking same question, because they will be asking the same thing repeatedly, because they will be doubtful. So why this is here? We will give an answer. Immediately he will ask again the same question because he is not listening to the answer. That is why they are. So a child who is repetitively asking them about one thing, you must suspect that he is having an attention deficit. Then you know that by 4 years, you know that all the children are very active. But a child who is not taking a nap or not sitting properly for his meal, definitely you must be thinking that he is having attention deficit hyperactivity disorder. And who is not at all lying down in the bed, even in the bedtime, he is very active, then definitely it is abnormal presentations. And impulsivity, again, you know that they'll be doing things without knowing the consequences. So definitely these are certain, and this can have a problem in a child for his academic activities, for his other activities also. And they are prone to, and you must understand that this can go beyond the infancy, childhood, adolescence, and adult. As adults, so many people who are making vehicle accidents, legal difficulties, problems at occupation at the workplace, definitely they are having this problem. Okay, so you have to identify it early and manage it early. They can have various associated problems like tics, comorbidities, etc. Comorbidities like depression will be there. Okay, so please mute all other microphones. And it is a problem of the frontostriatal part of the brain. And we know that the attention pathway is in the locus ceruleus, the striatal pathway, as well as the prefrontal norepinephrine pathway. That is why they have us. I just put it because to understand that it is a chemical problem. It is not a valartha dosha. So that always you must understand. These two pathways are the prefrontal pathway and the mesocortical pathway. By manipulating the dopamine and the norepinephrine, that is the importance of using drugs. Okay, so for the management, American Academy of Pediatrics advises evaluation in the initial phase, followed by treatment with drugs as well as with the behavioral therapy. So treatment options are medicine and the behavioral management. So always you have to think that this again is a multimodal treatment, but medical management is required. And the American Academy of Pediatrics recommends that stimulant medication must be recommended for these children with diagnosed attention deficit hyperactivity, especially beyond 6 months. And then behavioral therapy, where you will be giving the reward as well as the consequences, that means punishment. So, and another important aspect in the management would be the social skill training, where you may teach them to take turns and shares. So always whenever a child comes to me, I always tell them about the importance of sharing. And you can tell the care and the share shown by the parents. You tell them if the parents are not sharing and caring you, how you can survive. So tell them that you also share and care the others. So that is the best way by which you can manage attention deficit hyperactivity. I won't be going because my talk is not intended for that. So I won't be going into the details of those things. But anyway, using the positive reinforcement, rather than always pointing out the negative consequences, but point out the good things. And that also will be a definitely social reward, and it will be reinforcing for the child. Then coming to the other things, as I have mentioned, using negative consequences. Similarly, all of you know the importance of negative consequences, where a timeout or a specific punishment which are predetermined, because it should not be emotional outburst. And about the class management, work environment, etc. also is very, very important. And drugs which are used, one is methylphenidate and second one is atomoxetine. So all of you can prescribe atomoxetine, no problem. And always remember the dosage, 1 milligram per kg. So easily you can remember also. Even though people are advising diets, I don't think that diet, and there is no clear scientific evidence that ADHD is caused by diet or nutritional problems. So that you have to remember. Now going to the another neurodevelopmental problem, what is it? And the diagnosis, I think, by the behavior of the child itself, you can make a diagnosis, isn't it? This is a child with autism. Again, our aim must be to identify it early with the impairment, the socialization, impairment in the communication, and impairment, there is a repetitive behavior. So if a child is showing these three things together, definitely the child will be having an autism spectrum disorder. And so these are the things: decrease the speech, decrease socialization, and repetitive activity. So with this, you must be able to make a diagnosis. Okay, DSM-5 has, even though this triad is always helpful, the DSM-5 has made it into a dyad as a social communication disorder with a abnormal repertoire of behavior. That means repetitive behavior. Only, but again, because socialization, communication, there are a lot of things together. That is why it is considered as a social communication disorder with a repetitive behavioral abnormality. But again, autism, whenever you are encountering autism, you have to think of some other conditions where autism as a symptom, because autism, just like seizure, autism also can be a symptom. In this case, a child had a loss of purposeful hand movement, and there is a stereotypic movement, and developed microcephaly, then that child will be having a Rett syndrome. So earlier diagnosis of autism spectrum disorder with the different categories, now it is changed into a single spectrum that all of you must remember. And so the diagnostic clues are impaired socialization, where again, the impairment in the use of non-verbal behavior, that is more important, because even a child who is walking, talking, maybe this pragmatic aspect of the language will be affected. So identify that as early, and then looking for the repetitive behavior, where it can be external object related repetitive behavior as well as body related repetitive activity, as I have shown you. But that is important, because waving the hand, and another child who is just say this is an external object related repetitive, where they are just arranging the object like that, or a body related repetitive activity, where I think that video is there. But here he is, you can see that he is very, very adamant in using that coin by repetitively rotating it, and head nodding. Yes, yes. You can see how his dexterity in doing that. See, parents will say that, oh, he is so perfect in doing it. He can, an adult cannot do like that. But we know that he is excelling in one aspect, but he is deficient in all other things. So this is definitely a pointer for a autistic behavior. And impaired communication. Similarly, the language early, by 3 months itself, one can make a diagnosis, because responding, puckering their lips is a definite early sign. Similarly, when you cough to a 6-month-old child, they must be able to cough back. And similarly, telling polysyllabic sounds by 7 months, and dada mama by 10 months, and 2 words other than dada mama by 1 year. And 15 words, you can remember it as 1.5 years, 15 words, and they must be able to put together 2 words. And by 2 years, 150 to 200 words. So this is a normal language one is required. But again, to make a diagnosis of autism, you will give some concession, because 1-word sentence by 1 year, 2-word sentence by 2 years, and a 3-word sentence by 3 years. Definitely you'll have to, if a child is not telling this much language, then definitely it is an abnormal thing. For early diagnosis, again, for an autism spectrum disorder, again start by 8 months. This development of an object permanence, whereby child may not be playing peekaboo or a pate cake, is definitely an early indicator. Similarly, lack of proto-imperative pointing and proto-declarative pointing, where proto-imperative means pointing for something he wants, and proto-declarative sharing his and then this again would be a very, very, very important sign. That is what is called as the hand leading, where instead of using his hand to point to something, he is taking mother's hand. So this again is and similarly by 18 months, if a child does not look at you and point when she wants to show something, or look when you point to something, by at least by 18 months, definitely it is an indicator of autism spectrum disorder. Okay. Similarly, other social issues as can happen, as is shown in this picture. So may show no interest in children playing. The children are playing, but he is sitting away, or maybe vicious with the siblings, or may sit alone in crib, screaming instead of calling out for mother, or may not notice when the parent leaves or returns from work. All these are very early indicators, and definitely you must be making a diagnosis. And certain physical features also may be helpful. For example, as we can see here, a large face, prominent ear, prominent jaw, may be an indicator of a disease where autism spectrum disorder can manifest, like Fragile X syndrome. Again, see this. And even as late as this, where this child was very problematic in the workplace. And conditions with the tuberous sclerosis, again, they can have. Similarly, PKU or phenylketonuria. These are all some of the conditions where you can have autism spectrum disorder as a symptom. So these are the conditions: Fragile X syndrome, tuberous sclerosis, Leschnyhan syndrome, and PKU. These must be excluded in almost all cases of autism spectrum disorder. But again, look for the signs. Don't investigate for them unless there are certain clinical manifestations are there. Leschnyhan syndrome, because their self-mutilation will appear only by 3 or 4 years. So initially they will present only with the delayed developmental milestones and autistic features. Similarly, PKU, maybe there are subtle cases may present only with autistic features. So you have to look for a brown, it's a blonde hair. If that is there, then it may be an indicator. Similarly, for tuberous sclerosis, at least some clinical features like asterisk macule must be there. Then you will investigate in that line. So I think management aspect I won't be going, but again, pre-verbal speech simulation is very, very important, and identification of picture objects as early as, and getting less use of mobile phone and other thing. Finally, the most important neurodevelopmental disorder, learning disability. I'll just tell a few points about that and we'll conclude so that 5 minutes we'll get for some discussion. So here again, the triad of learning disorder will be dyslexia, dysgraphia, and dyscalculia. I think all of you know it, but again, a child who is having somewhat normal intelligence, who shows difficulty reading or difficulty writing, or difficulty in calculation, then you will make a diagnosis of specific learning disorder. Otherwise, a poor scholastic performance may be due to various causes. And the clinical features of an early diagnosis, because even in the preschool age, even though we will make a diagnosis of specific learning disorder only by the 3rd standard, there can be early indicators so that you can go for some remedial measures. And one among them is delay in speech development and fine motor skills. If a child is very clumsy from the early life, difficulty to rhyme by 4 years, confusion in word and space concepts, then as preschoolers, difficulty in decoding single words, mispronunciations, poor handwriting, awkward pencil grip, all these things may be an early pointers. So these are some of the remedial measures that we have to, classroom should be child-friendly. The teacher should be equipped with necessary knowledge and competence for educating children with it, because I have understood that after the learning disorder training program through the IAP, even many teachers were unaware of a specific condition called as learning disorder. When I asked them what is the reason for a poor scholastic performance, most of them were telling that either it is because of a poor friendship or because of the poor parental care. So that is it. And all of us must be aware of the social security measures. All of our children are eligible, like governmental program through which is SSA, that is Sarva Shiksha Abhiyan, where inclusive education for disabled children, and the BRCs. Similarly, the power of the PWD Act, where the people with disability, they are having the rights. They are yesterday. Through the Kottayam EAP, we were representing these aspects. And again, we must be able to use RBSK and the district early intervention center facilities. Then the Niramaya insurance scheme, for these children with autism, cerebral palsy, and Ashwasakarana, where the caretakers are given and various national scholarship programs for the students with autism, cerebral palsy, mental retardation. So they will be getting up to ₹1,000 per month, and different because class 9 onwards, and for professional studies also they will get. So finally, to conclude, we have understood that neurodevelopmental disorders includes intellectual disabilities, communication disorders, autism spectrum disorders, attention deficit hyperactivity disorders, speech language disorders, motor disorders. We have started with the motor disorders and various other neurodevelopmental disorders. To conclude, we have learned that we have to determine whether these disorders are static or progressive. And static disorders, the classical example is cerebral palsy with a central manifestation, with peripheral manifestation will be benign congenital hypertonia. And progressive disorder with a peripheral manifestation would be spinal muscular atrophy or muscular myopathies. And central disorders are various neurodegenerative disorders. And don't forget the treatable conditions where simple nutritional management or a nutrition to vitamin responsive disorders and various endocrinopathies, especially our hypothyroidism. So I told you that when a child presents, either it can be due to a cerebral problem or due to a spinal cord problem or a muscle problem. And don't forget to look for associated chromosomal disorders and thyroid dysfunction. And I told you that by just vertically suspending the child, you can understand whether it is child is having a low motor neuron disorder, upper motor neuron disorder, or the child is behaving normally. And a triad approach also I have mentioned, where for attention deficit hyperactivity, the two of the three triad, that is attention deficit and hyperactivity, is there in the ADHD itself, and additionally you remember impulsivity. So these are the three factors. Similarly, for the autism also we have learned the triad of impaired communication, impaired socialization, and repetitive behavior. And for learning disorder, the triad, where there can be the impairment of presentation to dyslexia, dysgraphia, or dyscalculia. I must say that by a caring mother and a caring teacher, we can definitely support these children. By that, definitely they will be having a good future also. Thank you.
Thank you, Professor Mohammad Kunjan. I think last 1 hour, he has covered the whole neurodevelopmental disorders in a very simple fashion, not putting too much neurology, only simple practical aspects that a pediatrician should. Now it is 12, we are 2 minutes late, so we are starting the function. That's a valedictory function of the Disability Awareness Week, IAP Kerala. ചരിത്രത്തിൽ ആദ്യമായിട്ടാണ് IAP കേരള ഏറ്റവും നല്ലൊരു പ്രോഗ്രാം ചെയ്ത്, അതായത് ഒരാഴ്ച മുഴുവൻ ഡിസബിലിറ്റിക്ക് വേണ്ടി എല്ലാ ദിവസവും വെബിനാർ കാര്യങ്ങൾ വളരെ നന്നായിട്ട് ചെയ്തിട്ടുണ്ട്. ഇന്ന് അതിന്റെ സമാപനമാണ്. അതുകൊണ്ട് എല്ലാ സ്റ്റാൾവേർഡ്സും ഇതിനകത്ത് എത്തിയിട്ടുണ്ട്. പക്ഷേ ഇപ്പോൾ OP ടൈമാണ്, എല്ലാവർക്കും അധികം സമയം ഇരിക്കാൻ പറ്റില്ല. അതുകൊണ്ട് ഈ ഫംഗ്ഷൻ 20 മിനിറ്റ്സിനകത്ത് തീർക്കണം എന്നാണ്. So, I request Dr. Bennett Sailam, President IAP Thiruvananthapuram, to welcome in 2 minutes.
Thank you, sir.
Bennett.
First of all, thanking MKC sir for arranging this program in a large scale, especially in NIMS spectrum. And we have seen, me and Riaz, Dr. Riaz has seen how the things are here. And thank you, sir. And let me go to my own job. Respected Chair, Dr. M. Narayan, State President IAP, Dr. K. Mohan, Vice Chancellor, PUHAS, Dr. MKC Nair, former Vice Chancellor, PUHAS, and IAP National President 2004, Dr. Ramesh Kumar, President-elect 2021, Dr. T.M. Ananta Keshavan, our Vice President, South Zone, Central IAP, Dr. P.N.N. Pisharadi, Chairman, Neurodevelopment Chapter IAP Kerala, Dr. Muhammad Unye, CAP member, Dr. T.P. Jayaraman, President-elect 2021, Kerala, Dr. Balajandar, State Secretary, Dr. Hasina, Dr. Riaz, present nominee, Kerala. You all know, as per WHO report, 15% of world population or more than 1 billion people are living with a disability. As the world recovers from the pandemic, we must ensure that the aspirations and rights of the persons with the disabilities are included and accounted for in an inclusive and accessible and sustainable post-COVID-19 world. The vision will only be achieved through active consultation with the persons with the disabilities and their representative organization. Disability, we know, the ability with the difference. Here I like to say two important persons, Pranjal Patel. She is the first visually challenged women IAS officer. We have to remember her. And Rajesh Kumar IAS officer, who is also a visually challenged, who played 3 cricket World Cup. So we got eminent persons with the disability. Our botheration is, of the 1 billion persons with the disabilities, that 80% live in developing countries. An estimated 46% of the older people, aged 60 years and above, are people with a disability. 1 in every 5 women is likely to experience disability in her life, while 1 in every 10 children is a child with disability. There is our role. So this year, theme is not all disabilities are visible. Let us work together for the betterment of our society and our children, especially in Kerala. Thank you very much. In this aspect, I welcome all the dignitaries of this platform to this meeting. Thank you.
Thank you. Thank you, Bennett. It was wonderful. അടുത്തതായിട്ട് പ്രസിഡൻഷ്യൽ വളരെ ബ്രീഫായിട്ട് ഒരു പ്രസിഡൻഷ്യൽ അഡ്രസ് കൊടുക്കാൻ വേണ്ടി കേരളത്തിന്റെ എന്നത്തെയും ഏറ്റവും ചുറുചുറുക്കുള്ള IAP പ്രസിഡന്റ്, അതായത് ഇമ്പോസിബിൾ മേക്ക് ഇറ്റ് പോസിബിൾ ആണ് അദ്ദേഹത്തിന്റെ. അതിന്റെ ഏറ്റവും വലിയ ഉദാഹരണമാണ് നാഷണൽ പ്രസിഡന്റ് കേരളത്തിൽ നിന്ന് വന്നത്, Dr. Narayan, and I am proud to say that he was my student. Excellent, Narayan sir.
Sir, mute ആണ്. Narayan sir, mute ആണ്.
Good afternoon to you all. First of all, thank you, sir, for the kind words. Dr.P.A.M Kunju, sir, Dr.K. Mohan, Vice Chancellor Kuhas, Dr. Muhammad Kunju, Dr. Ramesh, Dr. Bennett, Dr. Jayaraman, Dr. Anandakeshavan, Dr. Valedictory, and my dear friends in IAP. Today, we have entered the last day of the Disability Awareness Week, organized by IAP Kerala and different branches. I'm very happy that we could arrange programs on all these days, all the 7 days. And
Narayan, you are audible.
am I audible?
Yes.
Yeah.
Yes.
Yeah. And I'm happy that we could touch upon almost all the aspects of disability during all these days. And Disability Day, we have been celebrating, we've been observing. This time we are doing the Disability Week, and this will not end up with the week observation. And we have plans to have continued programs, and that is that we'll be coordinating, IAP Kerala will be coordinating child development activities in all districts through its branches, and IAP will act as a pivotal point, coordinating the developmental activities of the private hospitals as well as the district early intervention center. So we have been in touch with the pediatricians in charge of DAIC, and in the coming year and the years coming, we will be able to coordinate the activities, and we'll be utilizing the ASHA workers. Apart from what they are doing for the immunization follow-up, they will be trained to do the developmental screening also. And we have got a good number of excellent developmental centers across Kerala, and we'll be both in the private sector as well as in the government sector, and we will be utilizing the services for early detection of disabilities and early intervention of disabilities. IAP Kerala is blessed to have a former Vice Chancellor and the present Vice Chancellor for the valedictory function of this 1 week program, and I am thankful to both of you, sir. And also NIM Spectrum, CDRC, Neyatingira, who have been arranging this program, even though it's at the mid-noon where our pediatricians are busy. I think the key persons who will be carrying forward our mission are all present here. So, and I am also thankful to all the branch office bearers for conducting the program. So, thank you once and all. Thank you.
Thank you, Dr. Narayanan. അടുത്തത് എൻ്റെ കീനോട്ട് അഡ്രസ് ആണ്. കീവില്ല, നോട്ടുമില്ല, ഒറ്റ സെന്റൻസേ പറയത്തുള്ളൂ. 80-ൽ ചൈൽഡ് ഗൈഡൻസ് തുടങ്ങിയപ്പോഴോ, 87-ൽ ന്യൂറോ ഡെവലപ്മെന്റൽ ഫോളോ അപ്പ് തുടങ്ങിയപ്പോഴോ, 2000-ൽ അഡോളസെന്റ് പ്രോഗ്രാം തുടങ്ങിയപ്പോഴോ, 2015 പ്രീ മാരിറ്റൽ കൗൺസിലിംഗ് തുടങ്ങിയപ്പോഴോ ഒരിക്കലും സ്വപ്നത്തിൽ ഞാൻ വിചാരിച്ചില്ല ഇത് കേരളത്തിലെ എല്ലാ പീഡിയാട്രീഷ്യനും നെഞ്ചോട് ചേർത്തെടുക്കുമെന്നും ഒരാഴ്ച മുഴുവൻ ചൈൽഡ് ഡിസബിലിറ്റിക്ക് വേണ്ടി കൊടുക്കുമെന്നും. അതിന് ദൈവത്തിന് നന്ദി പറഞ്ഞുകൊണ്ട് എൻ്റെ വാക്ക് നിർത്തുന്നു. അടുത്തതായിട്ട് ഏറ്റവും ഇമ്പോർട്ടൻറ്റ് ഫംഗ്ഷൻ അഡ്രസ് ബൈ അവർ ചീഫ് ഗസ്റ്റ് മോസ്റ്റ് ഓണറബിൾ ഡോക്ടർ മോഹൻ, the Honorable Vice Chancellor of Kerala University of Health Science. അദ്ദേഹം ലൈനിലുണ്ടെന്ന് ഞാൻ വിശ്വസിക്കുന്നു.
Yes, sir. I'm here. Thank you, sir. Indian Academy of Pediatrics-ന്റെ ഡോക്ടർ MKC സാർ പറഞ്ഞതുപോലെ ഏറ്റവും ഊർജ്ജസ്വലനായ പ്രസിഡന്റ് ഡോക്ടർ M നാരായണൻ, എൻ്റെ മുൻഗാമിയും എൻ്റെ അധ്യാപകനും കേരള ആരോഗ്യ സർവകലാശാലയുടെ വൈസ് ചാൻസലറുമായ പ്രൊഫസർ MKC നായർ സർ, IAP-യുടെ നിയുക്ത ദേശീയ പ്രസിഡന്റ് ഡോക്ടർ രമേശ് കുമാർ, IAP-യുടെ തിരുവനന്തപുരത്തിന്റെ ഏറ്റവും ഊർജ്ജസ്വലനായ പ്രസിഡന്റ് ബെനറ്റ് സൈലം, IAP-യുടെ പ്രമുഖരായ നേതാക്കന്മാരെ, ബഹുമാന്യരായ IAP-യുടെ അംഗങ്ങളെ, പ്രിയമുള്ളവരെ, ഈ ഡിഫറൻറ്റ്ലി ഏബിൾഡ് വ്യത്യസ്തമായ കഴിവുകളുള്ള ആളുകളെ കുറിച്ചുള്ള ഈ ഒരാഴ്ചത്തെ ഈ ചടങ്ങുകളുടെ അവസാനത്തെ വാലിഡിറ്ററി ഫംഗ്ഷനിൽ പങ്കെടുക്കാൻ എനിക്ക് അവസരം നൽകിയതിന് IAP തിരുവനന്തപുരത്തിനോടും അതുപോലെ തന്നെ നിംസ് സ്പെക്ട്രം CDRC-യോടുമുള്ള എൻ്റെ നന്ദി ഇവിടെ ഞാൻ രേഖപ്പെടുത്തുകയാണ്. 2 ദിവസം മുമ്പ്, അതായത് 3-ാം തീയതി കേരള ഹെൽത്ത് യൂണിവേഴ്സിറ്റി തന്നെ ഒരു പരിപാടി നടത്തിയിരുന്നു. ഇപ്പോഴത്തെ കാലഘട്ടത്തിന്റെ രീതി അങ്ങനെയാണല്ലോ, നമ്മൾ ഓൺലൈനിൽ തന്നെ പരിപാടി നടത്തിയിരുന്നു. നമ്മുടെ ഏകദേശം 400-ഓളം അധ്യാപകർ ഈ പരിപാടിയിൽ പങ്കെടുത്തിരുന്നു. ഈ വിഷയത്തിൽ തീർച്ചയായിട്ടും IAP ആണ് ഏറ്റവും കൂടുതൽ പ്രോഗ്രാംസ് നടത്തിയത് എന്ന് എനിക്കറിയാം. ഇന്നലെ തൃശ്ശൂരിലൊരു പരിപാടി ഉണ്ടായിരുന്നു. അതിനകത്ത് എൻ്റെ വൈഫ് ഡോക്ടർ പാർവതി ഒരു പ്രസന്റേഷൻ നടത്തിയിരുന്നു എന്നുള്ളതും കൂടി ഓർത്തുകൊണ്ടാണ് ഞാൻ ഈ സന്ദർഭത്തിൽ ഇങ്ങനെ ഇതിനെക്കുറിച്ച് പറയുന്നത്. 2 ദിവസം മുമ്പുള്ള യൂണിവേഴ്സിറ്റി നടത്തിയ പരിപാടിയിൽ ഉദ്ഘാടന ചെയ്തുകൊണ്ട് ഞാൻ പറഞ്ഞ ഒരു പ്രധാനപ്പെട്ട ഒരു കാര്യം, ഒന്ന്, നമ്മൾ കോവിഡ് ലോകത്തെ മുഴുവൻ തകർത്തിരിക്കുകയാണ്. പക്ഷേ നമ്മൾ ആ ഇരുണ്ട നാളുകളിൽ നിന്ന് പുറത്തിറങ്ങാനുള്ള സാധ്യത കണ്ടു തുടങ്ങിയിരിക്കുന്നു. എവിടെയൊക്കെയോ നമ്മൾ വെളിച്ചം കണ്ടിരിക്കുന്നു. ഇന്നലെ നമ്മുടെ ബഹുമാന്യനായ പ്രധാനമന്ത്രി പറഞ്ഞിരിക്കുന്നു, ഇനി ഏതാനും ആഴ്ചകൾക്കകം ഇന്ത്യക്കാർക്ക് വാക്സിൻ കിട്ടുമെന്ന്. തീർച്ചയായിട്ടും നമുക്ക് അറിയാം, ആ വാക്സിൻ ആദ്യമായി കിട്ടാൻ പോകുന്നത് നമ്മളെ പോലെയുള്ള ആരോഗ്യ പ്രവർത്തകർക്കാണ്. അതിനുശേഷം സീനിയർ സിറ്റിസൻസിന് 60-ഓ 65-ഓ വയസ്സ് കഴിഞ്ഞ ആളുകൾക്ക്, അതുപോലെ തന്നെ ഡയബറ്റീസും ഹൈപ്പർ ടെൻഷനുമുള്ള ആളുകൾക്ക്, അവർക്കൊക്കെ നൽകും എന്നും പ്രഖ്യാപിച്ചിട്ടുണ്ട്. ഭിന്നശേഷിക്കാരുടെ കാര്യം ആരും പറഞ്ഞിട്ടില്ല. അത് പറയാത്തതാണോ അല്ലെങ്കിൽ അങ്ങനെ ആകും എന്ന് നമ്മളെല്ലാവരും വിചാരിച്ചിട്ടാണോ? പക്ഷെ ഇവിടെ ഞാൻ പറയാൻ ഉദ്ദേശിക്കുക, യൂണിവേഴ്സിറ്റി അക്കാര്യത്തിൽ വളരെ വ്യക്തമായി പറഞ്ഞു കഴിഞ്ഞിട്ടുണ്ട്. ഭിന്നശേഷിക്കാരെ പ്രയോറിറ്റി ഗ്രൂപ്പിൽ പെടുത്തിയിരിക്കണം. ഇത് പറയാൻ ഏറ്റവും ശക്തിയുള്ള സംഘടന IAP ആണ്. IAPയോട് ഞാൻ അഭ്യർത്ഥിക്കുകയാണ്, ഭിന്നശേഷിക്കാർക്ക് അവരെ പ്രയോറിറ്റി ഗ്രൂപ്പായി പെടുത്തിയേ പറ്റൂ. അതിൽ യാതൊരു കുറവും വരുത്തരുത് എന്ന് ഈ സന്ദർഭം ഞാൻ ഉപയോഗിക്കുക. പിന്നെ ഈ വിഷയവുമായി അനുബന്ധിച്ചിട്ട്, ഈ ഭിന്നശേഷിക്കാരുടെ പ്രശ്നവുമായി അനുബന്ധിച്ചിട്ട് ഒരുപാട് നാളുകളായി എൻ്റെ മനസ്സിൽ എന്നെ അലട്ടിക്കൊണ്ടിരിക്കുന്ന ഒരു പ്രശ്നം ഞാൻ ഇവിടെ അവതരിപ്പിക്കുകയാണ്. ഇതാണ് അതിന് പറ്റിയ വേദി എന്ന വിചാരത്തിലാണ്. നമ്മൾ ഭിന്നശേഷിക്കാരായ കുട്ടികളെ കുറിച്ച് പറയുന്നുണ്ട്, അവർക്കുള്ള കെയർ ഹോമുകളെ കുറിച്ച് പറയുന്നുണ്ട്. അത് കഴിഞ്ഞിട്ട് അവര് അഡൽട്സ് ആകുമ്പോൾ, അവര് മുതിർന്നരാകുമ്പോൾ എന്തു സംഭവിക്കും? ഭിന്നശേഷിക്കാരായ മുതിർന്നവരെ കുറിച്ച് വാസ്തവത്തിൽ ആരെങ്കിലും ചിന്തിക്കുന്നുണ്ടോ? ഭിന്നശേഷിക്കാരായ മുതിർന്നവരുടെ എണ്ണം വളരെയധികം കൂടിക്കൊണ്ടിരിക്കുകയാണ്. അതിന്റെ കാരണക്കാർ പീഡിയാട്രീഷ്യൻസ് ആണ്. നിങ്ങൾ ഭിന്നശേഷിക്കാരായ കുട്ടികളെ കൃത്യമായി സംരക്ഷിക്കുന്നു, അവരെ ആരെയും നഷ്ടപ്പെടുത്തുന്നില്ല. അവർ 18 കഴിയുന്നു. 18 കഴിയുമ്പോൾ അവർ പീഡിയാട്രീഷ്യന്റെ കയ്യിലാണോ? അതല്ല, അതിപ്പോ 21 വരെയായി, അവിടെ വരെയും പീഡിയാട്രീഷ്യന്റെ കയ്യിലാണോ? അവർ 35 ആകുന്നു, അവർ 45 ആകുന്നു. അപ്പോൾ അവരെ അതുവരെ പരിരക്ഷിച്ചു കൊണ്ടിരിക്കുന്ന മാതാപിതാക്കന്മാർക്ക് 60ഉം 70ഉം വയസ്സാകുന്നു. അതൊരു വലിയൊരു ഗുരുതരമായ ഒരു പ്രതിസന്ധിയാണ്. അപ്പോൾ അവരെ പരിരക്ഷിക്കേണ്ട ആളുകൾക്ക് പരിരക്ഷ വേണ്ട ഒരു കാലഘട്ടത്തിൽ ഇവരെ ആര് പരിരക്ഷിക്കും? അപ്പോ അതിനുവേണ്ടി ആരെങ്കിലും ശ്രദ്ധിച്ചിട്ടുണ്ടോ? തീർച്ചയായിട്ടും MKC സാറിന്റെയും മറ്റുമൊക്കെയുള്ള ഇടപെടൽ കാരണം പീഡിയാട്രീഷ്യൻസ്, ഇപ്പൊ സാർ ഇപ്പൊ പറഞ്ഞതുപോലെ ഒരാഴ്ച ഇക്കാര്യം ചർച്ച ചെയ്യാൻ തയ്യാറായിട്ടുണ്ട് എന്ന് പറഞ്ഞാൽ അതിന്റെ അർത്ഥം ഇന്ത്യയിലെ പീഡിയാട്രീഷ്യൻസിന് എല്ലാവരും തന്നെ ഈ ഡിഫറൻ്റ്ലി ഏബിൾഡ് ആയിട്ടുള്ള പ്രശ്നത്തെക്കുറിച്ച് വളരെയധികം ധാരണയുള്ള, കഴിവുള്ള, ഇടപെടുന്ന ആളുകളാണ്. നമ്മുടെ അഡൽട്ട് ഫിസിഷ്യൻസിനെ കുറിച്ച് പറയാൻ എനിക്ക് അത്രയ്ക്കധികം ധൈര്യമില്ല. കാരണം അവരത് അഭിമുഖീകരിച്ചിട്ടില്ല, അവരത് കണ്ടിട്ടില്ല, അവരത് കാണാൻ പോകുന്നതേ ഉള്ളൂ. അപ്പോ ആ ഒരു പ്രശ്നം അവിടെ നിലനിൽക്കുന്നു. തൃശ്ശൂരിൽ അങ്ങനെ ഒരു കേന്ദ്രമുണ്ട്. അത് ആ ഓർമ്മയിലാണ് ഞാൻ ഈ പറയുന്നത്. ഒരു 10-15 വർഷം മുമ്പ് തൃശ്ശൂരിൽ ഒരു പ്രൊഫസർ, ഒരു കോളേജ് പ്രൊഫസർ, അവരുടെ 2 ജ്യേഷ്ഠന്മാർ ഡിഫറൻ്റ്ലി ഏബിൾഡ് ആണെന്നും അവരെ പരിചരിക്കാൻ ആരും ഉണ്ടാവില്ല എന്ന ധാരണയിൽ അവര് തൃശ്ശൂർ മെഡിക്കൽ കോളേജിലെ അധ്യാപകരുടെ സഹായത്തോടു കൂടി ഒരു സംഘടന ഉണ്ടാക്കി, അസോസിയേഷൻ ഓഫ് ഹാൻഡിക്യാപ്ഡ് അഡൽട്സ് എന്ന് പറയും, മെന്റലി ഹാൻഡിക്യാപ്ഡ് അഡൽട്സ്. അതിന്റെ പേര് അമ്മ എന്ന് വിളിക്കും. ആ സംഘടന രൂപീകരിച്ച് അവരവിടെ ഇത്തരം ഡിഫറൻ്റ്ലി ഏബിൾഡ് ആയിട്ടുള്ള അഡൽട്സിനെ താമസിപ്പിച്ചിട്ട് അതിപ്പോ ഒരു 10-20 വർഷമായിട്ട് ഭംഗിയായിട്ട് നടക്കുന്നുണ്ട്. പക്ഷെ അത്തരം ചെറുകിട ഇടപെടലുകൾ പോരല്ലോ. അതിന് വലിയ രീതിയിലുള്ള ഒരു ഇടപെടൽ ഉണ്ടാകണമെന്നും ഇത്തരം ആളുകളുടെ പ്രശ്നങ്ങൾ എന്താണ് എന്ന് പഠിക്കണമെന്നും തീർച്ചയായിട്ടും ചെയ്യേണ്ടതാണ്. അത് യൂണിവേഴ്സിറ്റിയുടെ ചുമതലയാണ്, അത് നമുക്കറിയാം. അത് യൂണിവേഴ്സിറ്റി അത് ചെയ്യുകയും ചെയ്യും. ഡിഫറൻ്റ്ലി ഏബിൾഡ് ആയിട്ടുള്ള അഡൽട്സിന്റെ പ്രൊപ്പോർഷൻ എത്രയുണ്ട്, അത് അവരെ എങ്ങനെ പരിചരിക്കണം, അതിനുള്ളൊരു പ്രോട്ടോകോൾ, ഇക്കാര്യങ്ങളിലൊക്കെ ഉണ്ടാക്കുവാൻ കേരള യൂണിവേഴ്സിറ്റി ഓഫ് ഹെൽത്ത് സയൻസസ് അതിന് വി ഹാവ് എ സെന്റർ ഫോർ ഡിസബിലിറ്റി. അത് ഓൾറെഡി തന്നെ MKC സാറിന്റെ നേതൃത്വത്തിൽ തുടങ്ങിയിട്ടുണ്ട്. ആ സെന്ററിൽ ചെയ്യും. ആ സെന്ററുമായി സഹകരിക്കാൻ IAPയുടെ സഹായം വേണം എന്ന് അഭ്യർത്ഥിക്കാനാണ് ഞാൻ ഇത്രയും പറഞ്ഞത്. IAPയും യൂണിവേഴ്സിറ്റിയും കൂടി ചേർന്നുകൊണ്ട് ഈ വിഷയത്തിൽ കുറെ കാര്യങ്ങൾ ചെയ്യാൻ കഴിയും. കഴിഞ്ഞ ഒരു വർഷത്തിനിടയിൽ തന്നെ നിംസ് CDRCയിൽ MKC നായർ സാറിന്റെ നേതൃത്വത്തിൽ വലിയ കാര്യങ്ങൾ അവിടെ ചെയ്തു തുടങ്ങിയിട്ടുണ്ട്. അതിനുവേണ്ടി ഫെലോഷിപ്പുകൾ അവിടെ തുടങ്ങിക്കഴിഞ്ഞിട്ടുണ്ട്.
Sir, you are not audible.
രേഖപ്പെടുത്തുന്നു. നന്ദി, നമസ്കാരം.
Thank you, Dr. Mohanan, Honorable Vice Chancellor of Kerala University of Health Science, Indian Academy of Pediatrics-നെ സംബന്ധിച്ചിടത്തോളം ഇന്ന് ഏറ്റവും നല്ലൊരു നിമിഷമാണ്. കേരളത്തിലെ ഏറ്റവും പ്രഗത്ഭമായ യൂണിവേഴ്സിറ്റിയുടെ വൈസ് ചാൻസലർ തന്നെ ചീഫ് ഗസ്റ്റ് ആയിട്ട് ഈ ഫംഗ്ഷന് കിട്ടി എന്നുള്ളത് ഞങ്ങൾക്ക് വളരെ 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 സന്തോഷമുണ്ട്. അതിന് ഞാൻ നന്ദി പറയുന്നു. പ്രത്യേകിച്ച് ഡോക്ടർ പാർവതിയോടുകൂടി നന്ദി പറയുന്നു. വളരെയധികം ഈ പ്രോഗ്രാമിൽ ഇടപെട്ടിട്ടുണ്ട്. Team, the couple is very much interested in disability and programs like this. Thank you very much, sir. അടുത്തത് നമ്മുടെ ഏറ്റവും പ്രധാനപ്പെട്ട ഫംഗ്ഷൻ, ഇനാഗുറേഷൻ ഓഫ് ദ വാലഡക്ടറി ഫംഗ്ഷൻ ബൈ ഡോക്ടർ രമേശ് കുമാർ. അദ്ദേഹത്തെ പറ്റി ഒരു വാക്ക് പറഞ്ഞാൽ, ഇന്ത്യൻ പീഡിയാട്രിക്സിന്റെ ചരിത്രത്തിൽ ആദ്യമായിട്ട് ബോംബെക്ക് വെളിയിൽ നിന്നും സെക്രട്ടറി ജനറൽ ആയ വ്യക്തിയാണ്. ഏറ്റവും കൂടുതൽ വോട്ടോട് കൂടി തന്നെ അല്ലെ മാർജിനോട് കൂടി ഇന്ത്യൻ അക്കാഡമി ഓഫ് പീഡിയാട്രിക്സിന്റെ പ്രസിഡന്റ് ഇലക്ട് 21 ആയ വ്യക്തിയാണ്. കേരളത്തിന്റെ സാധാരണ രീതിയിലുള്ള, അതായത് പെരിഫറി വർക്ക് ചെയ്യുന്ന ഡോക്ടർ പീഡിയാട്രീഷ്യന്റെ ഏറ്റവും വലിയൊരു റെപ്രസെന്റേറ്റീവ് ആണ്. സർ, റിക്വസ്റ്റ് യു ടു ഇനാഗുറേറ്റ് ദ വാലഡക്ടറി ഫംഗ്ഷൻ.
Respected Chair, Dr. Narayanan, President of IAP Kerala, Chief Guest of the day, Dr. Mohanan, University Vice Chancellor, the patron of the Neurodevelopment Chapter, as well as the IAPNs of Kerala and the IAP of Kerala, and my own mentor, Dr. M.K. Nair, sir, Dr. Balachandran, State Secretary, Dr. Jayaraman, President-elect, Dr. Ananthakeshavan, the Vice President of Central IAP, Dr. Pisharedi, Neurodevelopmental Chapter Chairman, Dr. Bennett, as well as all the dignitaries on the platform, as well as all my DAs in IAP. Good afternoon, and I'm quite happy as well as delighted that we at IAP Kerala have been able to organize a week-long activities on different aspects of disability, touching all aspects of childhood disability this week. And this is quite unique in the history of IAP itself. Rather than celebrating, it's always been celebrating a day or being maybe some random activities at different parts, but a state branch or a branch for that reason taking up week-long activities, and that too very constructive, positive platforms where a lot of thoughts were shared, a lot of sensitizations has happened, a lot of new moves have been evolved over the last 1 week. And I must congratulate Dr. Narayan, President, as well as Dr. Balachandran, Secretary, and Dr. Pisharedi, and all those who have been, Dr. Ashraf, all those who have been behind this, for the great initiatives and the great thoughts and the execution which has happened in the last 1 week. And again, in the same note as Dr. Bennett Kunju sir has put it, and the social security aspect also, along with the in liaison with the social justice department, with Dr. Ashraf has a lot of listening with. We at IAP have been taking up all this, the activities in a big way with the district early intervention centers, the autism centers, and everywhere. Our pediatricians have been involved in a big way, and we have been able to contribute to the operationalize the disability moves for the aspects for the government in that aspect. And taking a cue from what Dr. Mohanan has said, sir, thank you so much for the great thoughts you have instilled. Two aspects you have rightly mentioned. One is regarding the vaccines for the disabled children, or on the priority basis. Of course, sir, that definitely I promise you I will be putting the moves from the central IAP on that regard, and making some moves with the government of India as well as the Ministry of Health and Family, wherever we can have the involvement. Of course, it will be, I think it is taken for, it is naturally it will be involved disabled. Our disabled candidates will be given the priority, but that can be put in as on paper from central IAP itself. And secondly, the thoughts which you have given, that disabled children and disabled adults, that is something which I had an experience maybe 3 days back when we conducted on the disability week. We had a meeting in in Apollo Hospital, Cochin, where I am working right now. Our dental department started a new initiative called the Smiles, where we called some children from the from Snega Southern, where we had some 20 inmates were called, and they were called to the hospital. They had a physical checkup and they had a dental checkup, and they had some talk from Madam Tiffany, who was a blind, and she had given a talk also on that day, plus some cake cutting and everything. But what I mean is, I was told that 20 കുട്ടികൾ ഉണ്ട്, 20 കുട്ടികളെ നമുക്ക് നോക്കണം സ്നേഹ സദനിലെ. 20 കുട്ടികളെന്ന് പറഞ്ഞ് ഞങ്ങൾ അവിടെ എന്നോടൊന്ന് പറഞ്ഞു, ഞാൻ എൻ്റെ ജൂനിയേഴ്സിനെ സെറ്റ് ചെയ്യുന്നു, കോപ്പി ഇടയ്ക്ക് 20 കുട്ടികളെ എങ്ങനെയും നോക്കി തീർക്കണം, ഓട്ടിസം ആയിരിക്കും കൂടുതലും, അല്ലെങ്കിൽ മറ്റ് ഇഷ്യൂസ് ആയിരിക്കും. പിന്നെ പറഞ്ഞു വന്നപ്പോൾ അവസാനം 18 വയസ്സിൽ താഴെയുള്ള 3 പേരേ ഉള്ളൂ, ബാക്കി 17 കുട്ടികളല്ല, ബാക്കി എല്ലാം അഡൾട്ട്സ് ആയിരുന്നു. ഇവർ 20 കുട്ടികളെന്ന് അവിടുത്തെ നേഴ്സിംഗിന്റെ അവിടുത്തെ മദർ പറഞ്ഞു. മദറെല്ലാം കുട്ടികളെന്ന് ഇവരെ കുറിച്ച് പറയുന്നത്. നമ്മളവരോട് കറസ്പോണ്ട് ചെയ്തപ്പോൾ ആരും അവിടെ പോയൊന്നുമില്ല. 20 കുട്ടികളുണ്ടെന്ന് പറഞ്ഞു. 20 പേർക്ക് പീഡിയാട്രിക്സ് ഡിപ്പാർട്ട്മെന്റിൽ സെറ്റ് ചെയ്തു. അവർക്ക് ഫ്രീ കൺസൾട്ടേഷൻ, പീഡിയാട്രിക്സ് ചെയ്യേണ്ട കാര്യങ്ങൾ, അഡീഷണൽ അന്ന് ഒരാൾ അവധി എടുക്കാൻ പറയുന്ന ഡോക്ടറെ കൂടെ എൻ്റെ ജൂനിയേഴ്സിനെ കൂടെ ഞാൻ സെറ്റ് ചെയ്തു. പാരലായിട്ട് ഒപ്പിയുടെ കൂടെ റൺ ചെയ്ത് പോകണം. കുട്ടികൾ എന്ന് അവർ ഉദ്ദേശിക്കുന്നത് മെന്റലി ആൻഡ് കോഗ്നേറ്റീവ്ലി ദേ ആർ സ്റ്റിൽ ചിൽഡ്രൻ, ബട്ട് they were all past the age of 18 years. Only 3 പേരെ ഉള്ള കുട്ടികൾ. So then we had the previous evening only we came to know that these are all adults. Then we took the help of the medical department, medicine department, which they were not aware that disability week is happening. ഇങ്ങനെ സംഭവം നടക്കുന്നുണ്ടെന്ന് പോലും അവർ, they were not at all aware. But of course, pediatricians like us, we are all sensitized and aware that this is happening, and we are very much passionate about it and involved about it. Sir പറഞ്ഞ പോലെ disabled adults is going to be something we need to evolve more and more methodology, how we need to take care of them in the future, because the seeds which are sown by MKC sir, Kunju sir, all our seniors, Ashraf sir, in Kerala itself and other areas, and all of us are taken IAP and pediatricians sensitized over the years, and we have been taking care of these disabled children or differently able children in a big way. So that has transformed more children into adults, and we have to evolve more for how best we can deal or rehabilitate them, make them good, take care of them. So naturally we'll be giving thoughts, and as IAP Kerala, along with myself from representing Central IAP, maybe the next 2 years we'll be giving more thoughts into it, and we'll be naturally coming out listening with maybe university KUHAS as well as other institutions in this regard. And finally, I would like to congratulate MKC Nair sir, who has done so much of being away from CDC for 5 years back, then as a vice chancellor coming back. We are so happy that sir is back with us with a bang. I believe in all aspects sir is taking care of, back to the good old days, golden days. He's back with us, mentoring all of us, taking our programs through, and through that what he has previously, the CDC tools, then Trivandrum tools, later now I believe then the NIMS tools will come up, or something which here can. Sir is working a lot on NIMS spectrum, so a lot of activities are coming there, and sir has taken the initiative for the program today. So we are so happy and blessed that MKC Nair sir is back with us after the vice chancellor. Of course, he has got a rich experience of the government governing the university also in that aspects. So everywhere, I believe IAP Kerala is on a great footing. And once again, congratulate Dr. Narayan Bala and all who have been involved with this, all the branches also, Trivandrum as well as the Kasaragod, all the branches which have taken up the activities in a big way. And we as a pediatric fraternity, we are there to care for the differently able children in the years to come under the umbrella of IAP and other similar organizations. Wishing I formally inaugurate the valedictory celebrations of the Indian Academy of Pediatrics Kerala State Branch Disability Week. But as President has said, this is not an ending. This is a beginning where we are going to put on the move many more projects which our future presidents and executive board will take up, I am sure, for the betterment of the disabled children. Thank you very much, and thanks for the opportunity. Thank you, sir. Thank you.
Thank you, Dr. Ramesh. I think all pediatricians in Kerala would be proud of your activities for the next 3 years. 21 as president-elect, 22 as president, and 23 as immediate past president. Thank you so much, sir. Now I request, it's an OP time. That's why I want to hurry up things a little bit, because most people has to go back to OP. So I request the South Zone Vice President, Dr. T.M. Anandakesavan, to join. I hope sir is there.
Very good morning, respected President Dr. Narayana, Vice Chancellor of KUHAS Mohan sir, past National President, young dynamic MKC sir, my friend and the National President elected Dr. Ramesh, all other dignitaries in the Zoom platform. It's indeed very happy to say that IAP Kerala is observing disability week for the entire 1 week. There are two things we have to note. One thing, first one is that it is only pediatrician. It's offering such a program in a wonderful manner. There are so many other specialties who are seeing the disabled children, either it may be ENT, orthopedics, whatever it is, but I think there is no such activities there. Second important aspect is that the credits go to Dr. Narayanan. The entire India, only Kerala is arranged this much of program. These are the two important aspects of this program. So as a pediatrician, as a KLH, you can really proud of it. Previously, we are offering breastfeeding week, ORS week, like that, the conventional, the so-called days, but totally changed nowadays from last 1 or 2 years. For example, Narayanan has rightly arranged child rights weeks, hearing-friendly hospitals. Now it is the disability week. All are socially oriented, very much important program. It is a real program. It is a need for the hours. So I think it is very, very important to see that. Anyway, I think we have to follow up the program in future also. I think Dr. Ramesh, our national president, and Dr. Jayaraman, state president, with the help of Dr. Narayanan, definitely will do a lot of activity. Here, I want to mention only one thing as such a special, because all the equipments, what we are seeing, disabled equipments for the disabled children, I am mainly aiming at orthosis, are very costly or we are not getting it properly. Hearing aid, we know there's some problem is there. Again, because I think many hospitals got their own, I am mainly speaking about the government hospital, I don't know others, but all are very costly also. Nobody, so usual, the family cannot afford all this equipment. We have planned to make it some cheap or very at a low rate, something like that. We have to plan because our children around they have to wait for 6 months to get the equipment. It means such a long period. So I think we have to take some initiative because walking and all this routine activities is very important for them. Speech therapy, I think so many extent it is doing, and other therapies we are doing it, and ROP screening we are doing it. All aspects we are doing it. But definitely the walking aids have something orthos will be definitely will help them. I think our coming office base will take action, will take necessary action towards this one. And once again, I congratulate IEP Trivandrum and IEP Kerala for organizing a wonderful week. And also, I wish my friend Ramesh all the best for the next year. Thank you. Thank you, Jai Hind.
Thank you, Dr. Anandageshwan, for making us feel proud. You have done a wonderful job in South India as the South Vice President. Thank you, sir. I invite Dr. P.N. Kunju, sir. He is the chairman of the Neurodevelopment Chapter of IAP. He is now left his practice and now concentrating whole effort in the district early intervention program. He is working in Ernakulam. I hope sir is there on the line. Dr. Pishardi, are you on the line?
I don't think so. His
I don't
name
think
is
so. Okay. Yeah, but I think to all the IAP stalwarts, I have a request. I think we should focus a little more on the district early intervention center, because this is one of the greatest achievement that we have made. I remember years ago sitting with the person who made it in Kolkata, planning the whole thing, and now it has come out. It's a government program. We need to support the government program. We may have one or two disagreement here and there, forget it. But we must make sure that this district early intervention centers function well, and IAP should contribute. Thank you, sir. Now we have the president-elect of IAP Kerala, Dr. T.P. Jayaraman. Sir, are you on the line?
Yes, sir. I hope I am audible.
Yes, sir.
Good morning, everybody. Respected President Dr. Narayanan, respected Chief Guest Dr. Mohanan, Dr. M.K.C. Nair, sir, Dr. Ramesh, and all other dignitaries on the dais. I am very happy to participate in this valedictory function of the Disability Week, first of its kind in the history of IAP, with lot of deliberations and thinking which has generated to give the directives for IAP to go forward in this field of disability. And as Narayanan told, we will continue the activity for years. That much I can tell. This will be one of the most focusing areas in the upcoming years of IAP. That is my belief. And as he told, we are planning to have some involvement of the ICDS workers and ASHA workers, and to go for detection of these disabilities at the early stage with proper referral, so that the discrepancy between the capacity and performance in these disabled children will be bridged. So that is the thank you all for the inputs, and let me sign off with a big congratulations to Dr. MKC sir. Actually, today morning I was talking with him, and he told today is the first anniversary day of his new venture, that is this NIMS CDRC. And my heartiest congratulations and best wishes, sir, for this activity. And I solicit all support for our activities in the field of disability, as well as integrating the work of DICCs in the coming year. Thank you all once again. And
thank you, Dr. Raman. I think we will continue with the Disability Week next year during your period also, I think. Thank you, sir. Thank you very much. We
that
have
is
now
100% definite, sir. I will be continuing.
the thing.
Thank
Dr.
you, sir.
Balachandran D, probably the most dynamic secretary of IAP Kerala. 38 years ago, I thought I was dynamic, but nothing compared to this man who has so much of energy. Dr. Balachandran.
Thank you, sir. Firstly, I am humbled with your words. Respected President IAP Trivandrum, Dr. Bennett Sailam, our State President Narayan sir, our Honorable Vice Chancellor Mohanan sir, our most respected MK Sinha sir, Ramesh sir, and the Yeshwan sir, EP Jairam.
I think Balachandran has a problem with the net. We'll hold on to it. Next, we'll come back to you, Balachandran. We have to invite Dr. Hasina. I understand she is tied up in the NICU. She may not be here free now. Please join, madam. No, I think she is not there. Yeah.
Sir, thank you, sir. Thank you. Am I audible? Am I audible?
Yes. Continue.
Okay. Respected KUHAS Vice Chancellor, IAP office bearers, MKC sir, Kunju sir, my teachers, seniors, and dear colleagues, a warm welcome and good afternoon. I should say at the outset that I'm extremely happy to be part of the NIM Spectrum Child Development Research Center, which was inaugurated a year back with none other than our dear Professor MKC sir as the director. I'm also thankful that I got the opportunity to study under eminent teachers like MKC sir, who is the doyen in developmental pediatrics, and Kunju sir, who is a great pediatric neurologist, then Naveen sir and PMC sir as great neonatologist. If not for these great teachers, we would never be able to set up an NICU and run the unit for this long, 10 years. And 10 years back, when we started the NICU, we had decided to set up a developmental follow-up unit in, as a humble background, like with one developmental therapist who we brought in from CDC, who was trained under MKC sir. And with her help, we could follow up our NICU graduates. And with effective teamwork from our pediatricians as well as staff nurses, we could ensure not only the survival of the newborns, but also ensure quality survival as well. And we have a 25-weeker 600-gram who is 10-year-old and well now, in spite of having treated for fungal sepsis and fungal meningitis. Similarly, there was an term baby with severe intracranial hemorrhage who is now 6-year-old and is walking, talking, and going to school and singing well. So this is not, this was only possible because of the classes and the training that we got from SAT and CDC. This is actually as a result of the early intervention and developmental screening, which is the CDC model of development, which was supervised and mentored by our sir. So at this 10th year, as the icing on top of the cake, we have the NIMS Spectrum CDRC, which has come up in our campus with sir as the director, and he has started IAP fellowships as well. And so I hope and wish, and I'm sure that this unit with early intervention as its crux will surely flourish and be of positive help to kids and families as well as society at large. Thank you, sir. Thank you so much, everyone.
Thank you, Hasina. Thank you so much. You look after the newborn so well. I think Balachandran can come back. Dr.
Yes,
Balachandran?
Yes, sir.
Yeah. Please come back.
Yeah,
complete.
Yes, sir. Sorry, sir. Yeah, I was telling that usually after the Child and Adolescent Healthcare Week, the energy of members will be at a low, and all members will be concentrating on reports and the state pedicon. But that doesn't deter our President Narayan sir, and he was going strong step by step. And in fact, he has planned another week activity before the state pedicon. That is the coming week. So this is the first time we are observing both Child Rights Week and Disability Week over a week. And I congratulate NIMS and IAP Trivandrum for excellently organizing this Valedictory function, especially to our beloved teacher MKC sir, who is back to IAP Kerala activities this year, which is a very great bonus for us. And I also congratulate on the behalf of state Kunju sir, Ashraf sir, who are here for the honor that bestowed on them by Central IAP. Thank you. Thank you. I thank all the members, all the branches for organizing this week with the various activities. In fact, this is the 10th activity. We have one more activity by Madhya Kerala branch today at 7:30 p.m. Thank you. Jai Hind, Jai AAP.
Thank you so much. Thank you, Dr. Balachandran. We need a person from Kozhikode also. I saw Dr. Ashraf, who was done an excellent job. He had done so much in the social security mission. He had made it a huge program for whole of Kerala. I think Ashraf sir, are you there?
Yes, sir. Yes, sir.
I saw a flash of it. Please say one word.
Okay, sir. Okay, sir. ശരിക്കും പറഞ്ഞാല് വർഷങ്ങൾക്ക് മുമ്പ് അക്കാഡമിക് തലത്തിലും ക്ലിനിക്കൽ തലത്തിലും MKC സാർ നട്ട ഒരു തൈ, ഒരു ചെടി, അത് പൂക്കുകയും പുഷ്പിക്കുകയും അതിന്റെ ഗുണങ്ങള് സമൂഹത്തിലെ ഈ പാർശ്വവൽക്കരിക്കപ്പെട്ട ആളുകൾക്ക് ലഭിക്കുകയും ചെയ്യുന്ന ഒരു സന്തോഷം ഈ സമയത്ത് പങ്കുവെക്കുകയാണ്. എന്ത് തന്നെയായാലും അടുത്ത കമ്മിങ് ഇയേഴ്സില്, അതായത് ഇന്ത്യൻ അക്കാഡമി ഓഫ് പീഡിയാട്രിക്സിന്റെ നെക്സ്റ്റ് പ്രസിഡൻഷ്യൽ പ്ലാനില് ഈ ഒരു മേഖല വളരെ സ്ട്രെസ് ചെയ്തുണ്ടാകുമെന്ന് വ്യക്തിപരമായിട്ട് ജയരാമൻ സൂചിപ്പിച്ചിട്ടുണ്ട്. വിജയകുമാറും അത് കണ്ടിന്യൂ ചെയ്യുമെന്ന് തോന്നുന്നു. എന്തായാലും ഡോക്ടർ നാരായണനാണ് ഈ വീക്ക് ഏറ്റവും ആക്റ്റീവായിട്ട് IAPയുടെ ചരിത്രത്തില് ആചരിച്ചത്. അപ്പൊ നാരായണനും സംഘാടകർക്കും എല്ലാവർക്കും നന്ദി പറയുന്നു. ഈ ഒരു അവസരം തന്നതിന് MKC സാറിന് പ്രത്യേകം നന്ദി. താങ്ക് യു സർ.
Thank you, Ashraf. അടുത്ത വോട്ട് ഓഫ് താങ്ക്സ് ഡോക്ടർ റിയാസിനെ വിളിക്കുന്നതിന് മുമ്പായിട്ട് ഒരു കാര്യം കൂടെ എനിക്ക് പറയാനുണ്ട്. നമ്മൾ എല്ലാ ഡിസബിലിറ്റി ചെയ്യുമ്പോഴും നമ്മുടെ ഫോക്കസ് ഇന്നലെ വരെ ബയോളജി പാർട്ടായിരുന്നു. സൈക്കോ സോഷ്യൽ പാർട്ട് ചെയ്യാൻ നമുക്ക് ടൈമുമില്ല, അത്രയ്ക്കൊരു ട്രെയിനിങ്ങും ഇല്ല. അതുകൊണ്ടാണ് നിംസ് സ്പെക്ട്രം ചൈൽഡ് ഡെവലപ്മെന്റ് സെന്റർ ഇന്ത്യയിൽ ആദ്യമായി, ഇന്ത്യക്ക് മോഡലായിട്ട് ഒരു ഡെവലപ്മെന്റൽ നേഴ്സ് കൗൺസിലർ എന്ന് പറഞ്ഞ കോഴ്സ് സ്റ്റാർട്ട് ചെയ്തു. ഇപ്പൊ 2 മാസം കഴിഞ്ഞിരിക്കുന്നു. ഇത് സക്സസ്ഫുൾ ആയി കഴിഞ്ഞാൽ അടുത്ത കൊല്ലം 15 സെന്ററുകൾ 60 പേരെ ട്രെയിൻ ചെയ്യണം എന്നാണ് ആഗ്രഹം. അത് കഴിയുമ്പോൾ ഇത് എക്സ്പാൻഡ് ചെയ്യും. അപ്പൊ നഴ്സസിനെ കൂടെ നമ്മുടെ കൂടെ നിർത്തിയാലേ നമുക്ക് ഡെവലപ്മെന്റൽ പ്രോഗ്രാം നന്നായിട്ട് ചെയ്യാൻ പറ്റും. റിയാസ്, I think voter thanks.
Yes, sir. Respected chair of the meeting, Dr. Narayanan.
Yes, ഒരു കാര്യം കൂടെ പറഞ്ഞോട്ടെ. ഞാൻ നേരത്തെ ഒഫീഷ്യൽ ഫംഗ്ഷൻ ആയതുകൊണ്ട് പറയാതിരുന്നാണ്. അപ്പൊ ഓണറബിൾ വൈസ് ചാൻസലർ is looking so handsome, unbelievably handsome today. Okay, now you start.
And our guest of the day, Mohanan sir, Honorable Vice Chancellor of KUHAS, our President-elect, our dear President-elect, Ramesh Kumar sir, then Kunju sir, who had given us a very beautiful class on how to identify and act on disabilities, our Vice President Anandageshwan sir, Pishardi sir, Jayaraman sir, Balchandran, Dr. Hasina, Bennett sir, and all the respectful seniors and teachers who are there in the forum. Actually, when MKC sir invited us to come and join the meeting here, so I was also thinking why, because we can join from home also, but it would have been a miss if we did not came here. Actually, I am seeing here a replica of CDC. I may say more than CDC because it is beautifully set, and I would like our friends in IAP to visit this also. And it is unbelievable that this all happened within a year, because from the stage of a PG student, I know how many years sir had spent to build up the CDC brick by brick. So I think it is much easier in the private sector, could be. And so we have 2 centers in Trivandrum for doing excellent child development care, and sir has started courses also. That is a great thing. And one word about IAP Kerala's dynamic leadership by Dr. Narayanan, because I should say that the first program Dr. Narayanan organized, a major program organized, was on child rights, and now he is ending with a disability. So these are areas which we seldom check upon. So actually this is opening a new avenue for pediatricians and actually Indian Academy of Pediatrics to act on. So this will be carried forward by the upcoming presidents. So congrats to the leadership, and I should officially offer a vote of thanks to our respected Vice Chancellor for joining us, and especially on a working day at a busy time. Thank you, sir, and you have given very clear messages what a pediatrician should do. One thing you have highlighted, that why there are disabled adults. It is actually, if pediatricians work more, you can reduce the disability in adults. That is a great message. We all should take up that. And Ramesh Kumar sir, as our president-elect, had given his ideas about how to go about. And I think with MKC sir back from the university, Ramesh sir can organize large programs all over which can spread all over the country in the IAP forum along with MKC sir. So thank you, Ramesh Kumar sir, for attending our program. And I also acknowledge the presence of Anandageshwan sir, because like MKC sir had told, at a time of Corona when everything was shut down, he organized an excellent conference of the South Zone of IAP. So I think it would have been the best ever organized, even though physical meetings were there before. Thank you, Anandageshwar sir, for all the support. Then Jayaraman sir is our upcoming president. He also has been deliberating with us in various areas. What are the actions to be taken for the president's action plan? And in his mind also, disability limitation is there, and he will take up in a big way. Thank you, sir, for attending the meeting. And our Ashraf sir had joined from Calicut, also in a working day. So thank you, sir, for joining us. And also thanks are due to Dr. Balachandran, who is the man behind organizing everything. Dr. Hasina, who is taking care of the NICU and also partnering with MKCSR in organizing the Spectrum, NIMS Spectrum program. And Pishardi sir, we missed you. I think we will have your presence in the upcoming meetings. And a huge thanks to our own President and Secretary, Dr. Bennett Silam and Dr. Priya Srinivasan, who has been organizing programs all over the year in different areas and in even the Zoom platform. And thank you for all your support. And thanks all the delegates who had joined the meeting in the Zoom platform as well as YouTube. And your presence had made the program a success. Thank you very much.
Thank you, Dr. Riaz. And now I'll request our president of the function, Dr. Narayanan, to close the meeting officially. Narayanan, sir, are you on the line?
Yeah. Dear all, just an excellent meeting, valedictory function, a combination of the first anniversary of NIMS Spectrum. And as Riaz has put it, now we have 2 centers in Trivandrum. We are looking for more and more activities, more and more advice from MKC sir, because we all learned the basics from him only. Now, when it's at the stage when we have to do more, because as it is that the mortality has come down and morbidity has increased. So now there is more room, more space for detecting the disability and early intervention. So again, we depend on, or we look upon MKC sir for activities like this in future also. Thank you all for attending this session amidst your busy working schedule. Thank you all. And the meeting is closed with your permission. Thank you.
Narayan sir, please stop YouTube streaming. YouTube streaming, please close. Narayan sir, you are the host.
You have to close.